Welcome, everyone. Thank you for joining us today for our webinar on the Canadian Women's Heart Health Alliance Atlas Chapter 8, Knowledge Gaps and Status of Existing Research Programs in Canada. Just a few housekeeping items before we get started. If you are having any technical difficulties or have a question at any point during the webinar, please feel free to type it in the Q&A section of the Zoom window. There will be a live Q&A answer period at the end of the webinar. Due to the nature of this public platform, we ask that you keep your questions general in nature. If you have a more personal question, we recommend you contact your healthcare provider. To ensure your sound is working properly, please check your audio settings by clicking Test Speaker and Microphone. And there will be a polling question at the beginning of the webinar. It is optional, but answering these polls are anonymous. And with that, I'd like to hand it over to Colleen.
Thank you so much. In her book, Braiding Sweetgrass, Indigenous Women, Scientific Knowledge and Teaching of the Plants, Dr. Robin Wall-Kimmerer reflects on the meaning of land to Indigenous peoples and writes, in the settler's mind, land was property, real estate, capital, or natural resources, but to our people, it was everything. Our identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the sources of all that sustained us. Our lands were where our responsibility to the world was enacted. It was sacred ground. It belonged to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings that people took with them when they were forced from their ancient homelands to new places. This is a picture of Half Moon Lake in Alberta, one of the tributaries of the North Saskatchewan River. There is evidence of Indigenous peoples living around this area and using this waterway as a main mode of transportation for thousands of years. Therefore, we would like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. While we meet on a virtual platform, we want to take a moment to acknowledge that we are visitors on this land and the importance of the lands that we all call home. We do this to reaffirm our commitment and responsibility to improving relationships between nations and improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home. Next slide, please. So we are so excited to present Chapter 8, which is the Knowledge Gaps and Status of Existing Research Programs in Canada, which was a voluminous chapter to get completed. And we're so grateful to the people who participated in this, and particularly Maria Claval, who led this chapter. Today we have 3 speakers. The first will be Jennifer, and she's a person with lived experience in heart conditions and stroke and volunteers for a variety of stroke and heart efforts, including the Canadian Women's Heart Health Alliance. She was only 43 when, without any risk factors, she had a stroke and discovered heart disease had happened also. She feels particularly invested in supporting healthcare and research on the heart and brain. Marie-Annick, or Dr. Marie-Annick Claval, is a professor at the Department of Medicine at Université of Laval and a scientist at Quebec Heart and Lung University Institute. She holds the Canada Research Chair on Women's Cardiac Valvular Health. And Lisa Cote Dr. Cote is a scientific associate at the Toronto Rehab Institute and Cardiovascular Prevention and Rehab Program in Toronto. As well, my name is Colleen Norris, and along with Sharon Mulvey, we will be moderating this session. Next slide, please. We would love to do a polling question to help ask who is joining us today. And if the poll is up, and if you'd kindly answer, that would be just wonderful. Just give that a minute. Oh, wonderful. Well, not so wonderful that we have no clinicians, but allied health, 45%. Good. We're strong in allied health. Thank you so much. And close that. So next slide, please. I just want to mention that we do not have any affiliation, financial or otherwise, with a commercial organization that may have a direct or indirect connection to the content of this presentation. And then I'm turning it over to Sharon for the learning objectives.
Thank you, Colleen, and it's a pleasure to be here with this esteemed panel. We're really excited today because I think that this session is going to enable us to gain insight into the existing education and research on cardiovascular disease in Canadian women, and to identify knowledge gaps, and this will enable guidance of our future research. We hope that we'll be able to come up with recommendations which prioritize women's health and are led by important research to achieve changes in how we actually treat women, and to be able to have policy systems and health systems policy changes, and introduce education and training about these important topics in our emerging workforce, as well as the existing healthcare workforce. And then finally, it's so important to have with us Jennifer, who is a person with lived experience, and she's going to share with us some very important insights regarding becoming engaged as a patient partner in research, and how this significantly can impact the course and future. Next slide, please. I think most of you know about the Canadian Women's Heart Health Alliance, and we're so excited that we were established in 2018. And honestly, we have come so far in the past 5-6 years. And our mission clearly is to be able to disseminate education and best practices regarding women's cardiovascular health amongst healthcare providers and amongst women with lived experience and the population at large. And I think we are making strides. We certainly hope that we will be able to overcome the gaps in many areas and be able to improve the health of Canadian women. Next, please. And we have done this through work that has been totally by volunteers. And we've assigned ourselves into different groups. Advocacy, where Red Canada is right around the corner, February 13th. I'm sure you all have it on your calendar. Training and education. Some excellent materials have been developed to be able to enhance the educational experience across the board. Research and knowledge generation is one of our newer project themes, and it's largely driven by the work that will be presented today, as well as knowledge translation and mobilization, which we have accumulated a significant body of knowledge, and we have put it together in the Atlas chapters, which of course this is the number 8, and you'll hear more about that from Colleen in just a moment. And then of course the ultimate, to be able to translate this into health systems and policies so that it can make a significant impact on improving cardiovascular outcomes for women. Next, please. Colleen, if you want to go over the Atlas chapters, and it's so exciting that we're at number 8 now, and there's only one more left.
It's just incredible. Thanks to the women at the Canadian Women's Heart Health Alliance. In 2018, with our hats in our hands, Sharon Mulvey and I went to our friend and colleague, Dr. Michelle Graham, who was newly minted editor of CJC Open, to pitch her on the concept of the Canadian Women's Heart Health Atlas as a vehicle to provide deep dives into each of the gaps identified in our original scientific statement published in the Journal of American Heart Association. That was authored by members of the Canadian Women's Heart Health Alliance. Michelle was incredibly supportive, and as another can-do person, the Atlas was born. This is the roadmap of the Atlas, which is organized into 9 unique chapters. Publication actually commenced in February of 2020, and the first through 8, actually 9 chapters have been published now. And chapter 8 and 9 will be published in the CJC Open special issue that's scheduled for Heart Health Month in February 2024. Each chapter is accompanied by detailed infographics that report on the current state of cardiovascular disease in women. The goal of the Atlas is to help clinicians and women in general recognize the unique aspects of women's heart health and provide policymakers with the information they need to ensure equitable care for cardiovascular disease. I might also add, because it's on CJC Open, this is open to the world. Each chapter is visible and able to be pulled down. I'd now like to pass it over to Jennifer for her to share her story and her experience with participating in research initiatives across Canada. Thank you, Jennifer.
Thank you, Colleen, and thank you for having me as a speaker this morning, or I guess this afternoon. My health story was already given, and now I'm going to talk about my research story, which began actually at about the same time as my health condition started to worsen, and I was becoming more aware of women's heart issues. And I was selected to be part of the British Heart Foundation in 2019, where I received several days of training on how to participate as a patient partner, a person with lived experience in research. Since then, I have joined a stroke telerehab study, where I'm a member of the research team, and I've had a great experience doing that as well. Next slide, please. If we don't all volunteer to become subjects in research, we won't be able to change this statistic. And that is that 2/3 of all heart disease research has historically focused on men. It's up to us, women, to find and volunteer to be subjects in research on our hearts. Otherwise, we will not be able to change that stat. And as well, next slide, please. These are some of the calls for action to patients and the public that are in Chapter 8. And indeed, research that is led by women focuses more on women's cardiovascular health. It recruits more women and ethnically diverse participants, and builds greater capacity for research expertise and leadership among women. If we don't volunteer as subjects in the research, we won't be able to have, for instance, the best practices or guidelines to be considered when developing those guidelines. They are not established on women. We need to participate as volunteers as a subject in women's heart health, and become aware of the importance of being a woman in research and how those factors impact health outcomes. And we need to communicate the importance of these factors. As well, lots of drugs were not studied or established with women involved in those research studies that had them become available to us. I'm on lots of drugs, but I have no idea if those drugs were ever researched on women. So those are really important to encourage you all women, to volunteer as subjects in studies. And I'll talk about this bottom two a little bit more on my next slide, and that is using our lived experience. Next slide, please. As a woman with lived experience, as a patient partner on a research team. And that is distinct from volunteering as a subject on a research team. As a subject, you're one of the people who is being subjected to whatever's being studied. As a patient partner engaged on a research team, you would be part of the research staff and part of that team. And this idea has been around in Canada for several years. The Canadian CIHR has the Strategy for Patient-Oriented Research, or SPORE. And their main goal is to ensure that patients, as well as researchers, healthcare providers, and decision makers, actively collaborate to build a sustainable, equitable, and accessible healthcare system, and bring positive changes to the health of people living in Canada. And I say that patient partners are also one of the next waves of health researchers. Trainees are obviously the next wave of health research, but I feel that patient partners are as well, because only through engaging with patient partners can we ensure that the research that's being done is relevant to patients, is applicable to us, if it takes the patient's experience and their perspective into consideration during the research. But to be a patient partner on a research team, we need to be trained. Also, the researchers need training on how to engage with us, similarly to our needing training on how to engage with researchers. We need a community to be developed, a community of patient partners, and we'll probably need a platform to find opportunities to both participate as a subject as well as be engaged as a patient partner. We have already, with the Alliance, developed the new Research and Knowledge Generation Projects theme, which I am a co-chair of, and I'm excited that the Alliance is taking a research in as one of its themes. And for that, we have received funding as one of 10 virtual hubs from the federal government that will fuel important research aimed at improving the health of Canadian women's hearts. We're also developing a new research application for the research network in women's heart and brain. And that is funding from the Heart and Stroke Foundation, as well as the Canadian Institute of Health Research. And it will enable cutting-edge interdisciplinary research that addresses the most urgent, in our case, our application is health for women's hearts, and address those research questions and those significant gaps in practice for women's heart. And I'm available if anyone has any other questions about being involved as a research subject, being part of the study, whatever's being studied, or being engaged as a research team member, and finally those final future objectives and projects. Thank you. And I'll pass it on to Marie-Annick.
Hi, good afternoon, good morning, everyone. I would like thanks a lot, Jennifer, for your presentation and for participating in research, both as a participant and also as a patient partner, because I'm a researcher, and as a researcher I know that the crucial importance of these two roles in research. So really thanks a lot. I would like to say also it was my pleasure to lead this new chapter of the Atlas from the Canadian Women Heart and Health Alliance. And I worked with an amazing team. That was a big job, but a really interesting one. So in this chapter, we focus on the existing gap of knowledge in women heart health and on the situation in Canada to fill out these gaps. We reported the existing research program with a specific focus on women and that are ongoing in Canada, and the place of heart knowledge in education according to sex and gender, and the education of future physicians and scientists, and the overall commitment to address these issues in the scientific community. So next slide. Thanks. So first, for cardiovascular disease, that we know that we have guidelines that guide the patient care. Interestingly, next click, none of these guidelines are sex specific. In some of them, that we could have 1 or 2 recommendations that are made for women, and often women are referred at in the special population section. However, we know that approaches to prevention, diagnosis, treatment, and care should consider the unique female physiology or gender roles and identities. And this physiology and roles could vary across the lifespan. New directive from Canada Granting Agency required application to address those sex and gender as biological and social variables. Thus, we made some progress over the last decade in the development of research study and program that are dedicated to women arts health. In the chapter, we aimed also to provide a list, which is non-exhaustive, of course, but we try to make it the most exhaustive possible, of the research programs that are ongoing in Canada. And we'd like to update this list in the future to add a lot and add a lot of programs, I hope in the near future, on the subject. However, despite the great evolution in the last decade, the improvement in research is far from sufficient in the topic, so in women heart health. And we have to increase again the research and the knowledge on women heart health. So we have to train the next generation of the scientists and physicians on the topic. Next slide. So we once again in the chapter we aim to report the level of the current education on the topic. So the Alliance launched a survey who explored the integration of sex and gender training within the training of so researcher and physician. And we have to be aware it's not really good. Indeed, we have only 35% of the trainee respondents that reported that their academic or research institution included sex and gender content in their course content, and only 8% have to be mandatory to report sex differences and gender based analysis in their dissertation. So we must be better. And we think that it is essential that the instruction in sex and gender-based research techniques be required in all research training programs. And with that, I will pass the virtual mic to Dr. Lisa Coty.
Thanks, Maria-Nic. I'm going to talk about intersectionality in research in women and some of the gaps that still exist. So as we slowly start to catch up in our understanding of women's specific experiences with cardiac health outcomes, we are unfortunately not seeing this same progress in our understanding when it comes to Indigenous and racialized women and their experiences with cardiovascular disease. So if we focus first on Indigenous women, we know that there's this continuous rise in cardiovascular disease and risk factors here. However, most of the research that does exist only provides these general estimates, and it uses a pan-Indigenous approach. So for instance, we often find ourselves using these broad terms such as Indigenous or Aboriginal. However, in Canada alone, there are hundreds of Indigenous communities using more than 60 different languages. Further to this, across those different communities, there's considerable diversity. We're talking about things like socioeconomic status, access to healthcare, education, social supports, and on and on. And of course, we all know that these have direct effect on health outcomes and cardiovascular disease risk factors. So the image that I have pulled up here is a figure from a 2017 scoping review by Stephanie Prince, who was at the Ottawa Heart Institute at the time. She was able to find 61 articles in the literature that reported on cardiovascular outcomes and specifically in Indigenous adult women. Great. Unfortunately, as we can see from the graphs here, the papers she found really only offer, again, these general estimates, and as I mentioned earlier, are all using this pan-Indigenous approach. So we can conclude, really, that addressing gaps in the literature of Indigenous women's experiences in cardiovascular disease will really require a much greater understanding of their specific experiences, but most importantly, from the lens of each diverse Indigenous nation. In order to do that, we need to have clear and accurate descriptions of these identities. And then we need to report our data based on identity or nation. Next click, please, Melissa. Okay, so let's shift and talk about racialized women. The 2021 census told us that within Canada, just over 1/4 of the population is comprised of racialized individuals. And if we look at that, then about half of those are women. In general, our understanding of cardiovascular disease in racialized populations in general is quite limited. Then add into that the experiences of racialized women specifically, and we're looking at extremely limited data. Additionally, racialized women's experience of cardiovascular disease vary quite widely across each of the different ethnic identities. So we are starting to have a better understanding of some of this research. And so what I've shown here is the effect of immigrating to Canada and what effect that has on a few different racialized populations. So the image I've pulled up here was published this month in Current Problems in Cardiology. So if you look at the bottom right, you can see they've separated out the females. Great. And what you can see is that women with African descent and South Asian women experience the greatest increases in hypertension upon immigration to Canada, whereas women of European descent and Chinese women experience minimal changes in hypertension prevalence with immigration to Canada. What this data tells us or highlights is the difference in experiences with cardiovascular disease between racialized women and those of European descent. We need more work like this. So we have a bit of a better understanding of the gaps that exist in our understanding of Indigenous and racialized women's experiences with cardiovascular disease. So let's focus in on some of the ways we might address these gaps. Let's talk about the currency of research, funding, and publications. What role do they play, and what's the current status to encourage intersectionality in research? All right, let's start with the good news. It seems that some granting agencies have started to receive the message and are beginning to take steps in the correct direction. For instance, federal granting agencies now require the integration of sex and gender as variables into all of their applications, or in lieu of this, a presentation of the rationale as to why it hasn't been included in the application. So on the screen, I'm showing a few federal opportunities with specific focus on sex and gender. And even one on the left in the middle there, you can see includes Indigenous populations. So you can find more information about each of these opportunities in the actual chapter itself. And I believe Melissa's posted a link to that chapter in the chat. Although this is good, it's progress. It's still not enough. More is needed. And unfortunately, provincial and local granting agencies do not consistently have this requirement to include sex and gender. Policy change to require the integration of sex and gender, and better yet, intersectionality into all funding applications is needed and strongly recommended. Change slide. Sadly, we're just not seeing this progress when it comes to journal publication guidelines. If we go back to what Marie and Nick spoke about earlier and the lack of women's specific guidelines, a huge part of this is because if there's no data, then recommendations and guidelines can't be made. Thankfully, the CCS was able to publish a clinical practice update on the management of cardiovascular disease in pregnant patients. However, other guidelines have had trouble to be created just due to the lack of data and evidence that exists in the literature.
There have been many, many, many calls by international societies for sex-specific reporting, but very, very little action in response to these calls. In response to the extremely low level of sex and gender disaggregated data, the Sex and Gender Equity in Research, or the SAGR guidelines, were created by the European Association of Science Editors. Big step, great, right? They can be used for everything from funding applications to manuscript prep. They've been translated to 6 different languages. Their use is encouraged, not mandatory, but encouraged by large funding agencies like CIHR. The endorsement of these SAGR guidelines by journal publications supports identifying and recognizing sex-specific experiences. Ready for the bad news? None of the endorsing organizations of SAGR are cardiology journals. So, while recognition of the importance of researching, identifying, and reporting women's specific experiences of and treatment for cardiovascular disease has been recognized, and numerous calls to action have been published, the action in response is sorely lacking. Change slide. Okay, so if we dive even deeper into this problem and the root of some of these issues and ultimately gaps in knowledge, we see that there's a severe lack of representation of women across the cardiovascular sciences, across surgery and medicine within Canada. Interestingly, studies across several published sciences, including medicine, have shown that women are less likely than men to be first or last authors. So what you can see on the screen here are a couple of graphs showing 2018 to 2021. The purple bars are men and the orange bars are women. And this is showing the first and last authors in many high impact scientific journals. Next slide, please. Okay, so busy slide, so I'll just kind of orient you to the graphs here. Same idea as the one before. Purple bars represent men and the orange bars represent women. And what each one of these different graphs represents a high impact cardiology journal. And so what we're seeing here once again is that we can see that women are also less likely, if you specifically look at the top row of each of these different graphs, what we can see is that women are also less likely to be editors, members of editorial boards or reviewers, and this is occurring especially in high impact factor cardiology journals. This likely explains, or at the very least contributes to the shortage of women at the top ranks of academic positions. Next slide, please. Effective knowledge translation of new information gathered from research obviously enables the development of guidelines like Maria, Nick, and I both spoke about. And then when we apply these clinically, we improve patient outcomes and ultimately reduce healthcare costs. So we already talked about publications, but other forms of knowledge translation are also extremely important. There's data to actually suggest that women's heart health research is less likely to be presented at conferences, or if it is presented, it's often relegated to categories described as a subset of special populations. These sessions are often concurrent and held in smaller side rooms, like you can see on the image on the left. What this does is send the message that they're not quite as important as the main, very well-attended symposia sessions in the big main auditoriums, the picture on the right. Unfortunately, what this does is just perpetuates the problem. So I'm going to hand it back to Maria Nick to summarize the chapter. Thank you.
Thanks a lot, Lisa. So this is the slide that the figure that summarizes our chapter. I won't go through the figure completely and read all the boxes. This is not the point. Just wanted to say that we reported all these gaps and the states of knowledge and representation of women within research, publication, education in Canada, with the topics of a woman heart health. And this is the way actually to highlight that there is some improvement this last decade, but we are really far from arrived. You know, that we have to do more, we have to improve again, and we still have things to do, and thus we need action, concrete action, to fill out the gap, to improve the life of women with cardiovascular disease for all Canadian women. So just briefly, because we went through that with Lida and presenting the chapter, that we need to improve education by including sex and gender-based techniques within the training of our future scientists and physician. We need to improve the reporting, the scientific reporting of the knowledge on the topic in both journals and conference with the same size, the same impact factor, the same importance, if I may say, than other data are reported to. And we have also to acknowledge the new findings to the general public, to the women with heart disease, and to the women in general, that the women will know that they are at risk for several diseases, and they could take care of themselves. And we have to increase the representation of women within research. So within research study, but not only within research team and within a leading position. In the university research center, journals and conference board conference. And with that, with these hope, I will send the mic back to Sharon.
Wow, thank you all for excellent presentations. Jennifer, your passion and commitment and the challenge that you are dealing with after your cardiovascular event, to have the confidence to be able to share all of this with us and to be so proactive in your contributions. A huge thank you very much. And Mary-Annick for leading this chapter, and just a huge amount of information to bring together. Fortunately, there's information to bring together, but more importantly, recognizing the paucity of information, the gaps, and being able to develop a way that we can move forward. And Lisa, that was a great summary on the details of trying to understand what are the pieces that we are so neglected in research as women in the cardiovascular space. I think that, we are making progress. I would absolutely agree, but it's been a bit slow, and it hasn't been consistent. A pivotal change was certainly the funding requirements from the CWHHA and the Heart and Stroke to demand that there be sex and gender statements addressed within any application or explanation for why they're not. I mean, that has been huge. But as Lisa clearly outlined, this is not really translated into the data, the actual amassing of information that we have available to us to consume in publications or presentations at meetings. And, the whole special populations terminology for women has always and certainly mystified so many of us. But I think we are at a very pivotal turning point because it's being called out. We are recognizing this, and it's because of the work that is being done by all of our colleagues that this is actually going to make a change, and so that we will then be able to get down to the business of actually reporting the research in the way that it should be done and having that actually published so that that information is disseminated to all. I think it's a very special time that we're at right now. We have more that we need to do, though, as clearly outlined, and the importance of intersectionality. Just the first bar is sex and gender, and then the other contributing factors racialized women, ethnicity, cultural aspects, social determinants of health. All of those things need to be brought in to have further understanding. And I think, Lisa, you brought those points out extremely well. So we do have a list of action items, and they're much more comprehensive than what are on this slide right here. And I would encourage all of you to please go and read the article because it took a lot of work to put it together, and including survey of the situation as was presented by Mary-Unique in her talk as well. So we can see there's a lot of work to do. So I'm going to open it up for questions, and I think we're getting a couple. So please, we would ask that you put the questions in the, I believe we're putting them in the Q&A box. And I think that the first comment here is from Catherine. Good enough. Catherine, thank you so much. Your comment is that you are a very engaged patient partner as well. And particularly to thank Jennifer for all of the support that you have provided, Jennifer, in pushing, is the term that Catherine has used here, and encouraging women with lived experience to become involved in research. And the whole concept that you presented about as subjects, we are familiar with that for decades now about research subjects, but the whole idea of patient partners in research, being at the table as a patient partner, is key. And I think that has really catapulted the development that we have seen going forward. And I'd like you to share with us just a little bit more about how you think that women should go about doing this, and how, in your experience, maybe some tips and tricks to be able to get involved, and why you do it. You know, I think you shared quite a bit about that, but I would like to hear you expand on that a bit more.
Sure, thank you. I was a younger stroke survivor and a younger cardiomyopathy patient, and now heart failure patient. And I found that if I wasn't going to get involved and start making changes to research, you know, my daughter might be in the same boat. It turns out mine is not genetic, but just her generation, and that's one of the big reasons why I'm involved, and because I am one of the WOWs, the white women of I can't remember what it stands for, but the idea is, you know, I am fortunate to have the energy and the time to dedicate to it because I am retired early because of my health. So that's why I do it. And the fact that research has become quite important to me, that was just because of my experience, my initial experience in Britain, and then my experience being on the local tele-rehab study. It's all been positive. And I can see the importance of ensuring that our voice is part of the research, that you know, we're there from the beginning, like to come up with ideas that are important to me and other patients dealing with heart research. And you know, we need all kinds of heart research going on, but we also need a section that is valuable and relatable and important for our actual patients. And that's one of the items on my to-do list. Yes. And I encourage others to, you know, you don't need a degree to become a patient partner on a research team at all. You have expertise being a patient who has lived expertise, and that asset, try and look at the bright side of having heart failure or a heart condition. Having that experience can allow you to become involved in research, and bringing that expertise to the table is now it's being required by CAHR and other funders. So you should get on board and get familiar with it and join me.
Thank you very much, Jennifer, for all your commitments, especially, and the phrase you use, bringing it to the table. And the phrase that I always remember is like, if you're not at the table, you're on the menu. And that is kind of where I think it's been for women's cardiovascular research. We really, it's been kind of relegated to the parsley on the side, more or less. And that would brings me to the question that I have for Lisa. And that is, that picture that you showed of the meetings. We all go to a lot of conferences and that. And, the relegated to those little side meetings. I mean, sometimes like small groups are very important because we can actually get things done. But to actually translate and disseminate knowledge, it's not, really the plenary session, right? Which is over in the other image that you showed. So what do you think is the best strategy? Do you think that the best strategy is to try to get women's cardiovascular research and the results reported in main sessions at meetings, or is it better to grow those side sessions so that there's more awareness and more in depth, or should it kind of be both? And maybe just a little call out there to the Canadian Cardiovascular Society and what they have done in working particularly with the Canadian Women's Heart Health Alliance and the presence at our Canadian Cardiovascular Congresses. So what do you think? What's the best formula there, and how should we go about?
I think both, for sure. I think certainly it needs to be included in the big main symposia, the big rooms, the big, the main attendees, everybody's there. But as you said, those smaller side rooms, sometimes we get more things done and there's more discussion, and, it's really great. I think there's been a lot of progress. We have the Canadian Women's Heart Health Summit. It's literally dedicated to women's heart health. But having said that, we're sort of preaching to the choir there, right? Mm-hmm. Everybody who attends that conference is a huge advocate of women's heart health. And sometimes those aren't necessarily the people that need to hear the messages, right? And so we need to continue to do that. It's incredible, but we also need to get our foot in the door in every conference. And whether that is the side rooms, that's fine. But yes, we need to promote those talks and those topics, and the importance of the special populations. I feel so lucky to be called special, but we need to be a little better at that and really promote that, but then also include women's heart health and intersectionality and all of this in those big main symposia as well, because it really does send a message. We're doing I'll just do a quick little anecdote. We're doing a model change in our cardiac rehab program, and it's really important the language that you use. If you say the word optional, it sends the message it's not as important, right? And so if you say special population or these subsets or whatever, it sends the wrong message. If everything is messaged as equally important, that's the message people receive, and that's the response you're going to get to that.
Great point.
I think and one other thing that you said that was really important when you were presenting that is that they're at the same time too, right? Like, so your special session is at the same time as a big, and I guess the way we change that is get on the committees that are planning the symposium, saying, no, we can't have these two at the same time. But, that's a big issue. I was going to say something else about that, because it's such an important issue to get the message out. But I know you were talking about the journals and the SABR guidelines, and it's really, really been interesting to me, even last fall, where we were given revise and resubmit on a woman. We only looked at women, and we were told to provide the table of the men. of the same age group and their demographics. And we only looked at women, and this is a top journal. And, I think we have to keep writing back to editors and saying, no, like this was a woman's study. Where am I even going to get, the men's demographics? I guess from the last 50 years, I can pick a cohort and compare it. But anyway.
Yeah, I think those are really good points. And the other thing that's, extremely important is we need to have more women involved as the investigators. And I'd like Marie-Annick to share with her from the research point of view, her point of view with respect to, why are women less represented in clinical research? And do you think it might have anything to do with the fact that we have fewer women that are in, not only as Lisa put in her graph very beautifully about, unfortunately, all of the major journals with respect to publications, but what about principal investigators on research studies and, having the questions asked? And, we've got some really positive moves right now with the funding opportunities that, have been mentioned as well. I think that's going to really push the field forward. And I can't thank enough to our, governmental and foundation leaders that are listening to our requests. But how do you think that we can get more women investigators and pursue that?
Yeah, I think that it was a huge improvement to have the CIHR and Heart and Stroke requiring that we talk about sex and gender in the application. Unfortunately, it is great. It's the two great most higher agency in Canada, but it's not the same when we go to local agency or provincial agency, and it should be actually. It should be mandatory for any research grant that we should have sex and gender based analysis somewhere. This being said, well, it's true that to have more women, more research about women, that we need more women principal investigator, more women in the research team. That is, has been shown that if the first or last author is a woman, that you have more chance to have disaggregated data by sex within the manuscript. So yeah, so now how to have more women in the research field. This is difficult. You need to have women in leading position, in university, in academic center, in research center, because you have to hire those women that's going to be researcher. You have when you look at the majority actually of the academic center, that you have really less women being researcher than scientists and than men. And it's shown on the manuscript, on the published manuscript. You have, as Lisa said, that you have very few, few, because when it's less than 20% of the published paper, it's few women as the last author or the first author of the manuscript. So yes, we have to change that. I think it's not going to be easy, but yes, we have to change that.
So, I think it really has a lot to do with mentoring too, right? And I just, when we say kind of that 20% number, I mean, that's kind of been the static number, maybe 15 to 20% of women in cardiovascular sciences for decades now, right? So I think that actually when I looked at Lisa's graph, I saw kind of like a little tiny signal of some hope there, that when we looked at the first authors that were women, it was a little bit further that the orange bars were out. Excuse me, than for the senior authors, that the orange bars weren't out quite so far. So maybe, and I do think we are seeing this in our cardiology programs across the country, excuse me, that we are attracting more women into the cardiovascular sciences, both as physicians as well as investigator PhD level. And I think that this is going to make a huge difference. But it gets back to, why didn't women want to do it in the first place? Medical schools, graduation, 50-50, even a little preponderance of women over men graduating from medical school. So we have to make cardiovascular sciences an attractive occupation, an attractive career choice. And I would like to just call out again for the Canadian Women's Heart Health Alliance in what they're doing. They actually have a high school program where mentors go into women with lived experience, share their information, their experiences with why we need to do this, why it would make it interesting, and then to have actually individuals that are already involved in cardiovascular sciences to be sharing their experience and their information with our younger population. And I think that this is hopefully going to make a difference going forward. And so many things have happened culturally too with respect to understanding and making it a better situation for women in cardiology programs and residencies. I would just, maternity considerations, all of these issues that we're making it not a very good lifestyle choice in the past. So there are some old battle axes around like me that have, survived a lot over time, but we really do need to encourage our younger colleagues, our younger population, to see that this is a very rewarding type of career, and that we need to make it engaging and make it interesting. And I think that there's a lot that's being done by the Alliance to go in that direction. So we do have a question in the chat, in the Q&A, and it's really an excellent question. And I think, Jennifer, you're already addressing it by typing it, but maybe you want to say, Nancy Hansen has asked a specific question there about how to really find out about research studies and research opportunities as a woman.
Yes, and there is no platform that deals specifically with heart research or women's research that I know of, but they can go, for instance, on the Heart and Strokes website, participate, and they would find both opportunities to be a subject, participate as a subject, as well as opportunities to get involved as an engaged patient partner. In BC, we have a website called reach.bc, and it also has both of those listings available on it. You can sign up and you can check off heart if that's what you're interested in, and then they'll send you weekly updates about what is available, which is helpful. But that's one of the platforms I think, for instance, the Alliance perhaps needs to consider developing.
The other thing that we can do as researchers that we've been doing is like we have created a registry for women's heart health in Edmonton. And when they fill out the survey, at the end of the survey, it says, would you be interested in participating in other research? And it's just been a gold mine, honestly, for us, because it's like 98% of the women who participate in the survey in the registry are saying, yes, I would. And I think that's the way of moving forward, because then we have, 5 or 6 studies that are ongoing that they could say, yeah, that's something I'd be interested, this intervention study or whatever. And the other thing is that it behooves us as researchers to make it more, not easier, but to make it more that women will participate. So a couple of the things that we've done is we offer, it's not just a parking, because parking is crazy where we're at for research, but we offer, you can get an Uber or a taxi to take you to our research. And the big thing that I think is going to change it is we use now a Jane app. So we're not telling them to come in on Tuesdays because that's the day we're doing the measurements. We use a Jane app so that they can book when they can come in. Here's the days that we'll have someone that would be available to do this study. And I just think things like that we think about a woman's lifestyle and what they're, instead of fitting them into ours, we're fitting into their life.
And I think just to jump in there and add to that, I think this just really highlights the importance of patient partners. So be a part of the team, help us as researchers figure out what is the best way to communicate this to our participants. How do we best advertise? Where do we advertise? Like all this type of thing really highlights that important, one of the many great reasons why it is important to have patient partners. And then another maybe small piece of advice would be, if you want to be really active as a participant to try to seek out studies, you could go to your clinician, you could go to your cardiac rehab program, you could go to whatever and just ask, are there opportunities? Do you do research? If not, do you know where there is, this type of thing? So, be your own advocate. Although it is the responsibility of researchers as well, but be your own advocate as well, and ask and make those questions.
That also helps create the awareness amongst the clinicians.
Yeah.
Turn around and think, yikes, they're asking me. I better find out what's being researched right now, right?
For sure.
And actually, there's really excellent table in the article in Chapter 8, which summarizes all of the research programs that Maria Nick and the team could find across Canada. So that's where you actually get names of individuals to be able to approach, investigators, et cetera. So that would be an opportunity. So
yeah, and you have the mail, and I think that just jump in and just write a mail to the researcher, to the team.
Exactly, to the topic that you're particularly interested in, because we have to get that all of this really is fuel. All of this is fuel to be able to feed the research. We can't do research if we don't have participation in subjects, and we need that fuel to take it forward, to then be able to get the evidence to be able to change guidelines going forward, and that changes practice. Practice changes will cause changes for the better in outcomes. So that's kind of the pathway and the pipeline, so to speak. So I just want to thank everybody for their participation today. I can't believe the hour is up already and we have to sign off here. But before we do that, I'd like to remind everyone our next webinar is actually going to be featured on February 13th, which is Wear Red Canada Day. And so we'll go to the website and you'll get all the information on that. And that is going to be our culmination of our experience with putting these chapters together. And I think that you will really enjoy it. And we're going to go into more depth and detail on call to action and how to make equitable approach to cardiovascular issues in Canada. I also would like to remind everybody, please, to fill out the evaluations. We really do use your information that you send back to us to be able to develop our programs going forward. And just want to thank you all of our panelists, my co-chair, Colleen, and our participants for joining us today, for making this all worthwhile. And carry the torch, go forward, and we'll see you soon. Take care now. Bye-bye.